Perspective I would like to bring to this is, I think, very suitable to this launch. That is a concrete example of collaborative efforts to improve the access to person-centered care in a specific disease. So in diabetes, where we now have an estimated 360 million people with diabetes worldwide, highlighted as a major disaster unfolding in slow motion in front of us by the UN, we are faced now with huge challenges to deal with this condition in a cost-effective way. And the last 10 years, we have worked internationally with the International Diabetes Federation and major organizations to try and create an international consensus and collaboration on how do we implement patient-centered healthcare in diabetes. And I know we have several experts here in diabetes as well. So my talk will really be, very briefly, 10 years of experience working internationally to implement patient-centered healthcare in diabetes. What have we learned that is relevant for this important launch of these disease-specific initiatives? And secondly, some personal thoughts as well on what is important here. So to scroll back time 10 years, exactly in the fall of 2001 actually, the International Diabetes Federation, together with major organizations, came together and said, it cannot be true that more than half of people with diabetes worldwide are not achieving good glycemic control, are not achieving good health, despite effective medicines. So the biggest study of its kind, called the DAWN study, Diabetes Attitudes, Wishes and Needs, now publicized and cited as the most cited psychosocial study in diabetes in more than 300 peer-reviewed articles. We have a book here summarizing the 10-year achievements. That was launched in 13 countries with interviews of doctors and nurses and patients to understand all the person-centered aspects of diabetes medicine. And WHO, IDF, FEND, PCDE, many organizations and multidisciplinary delegations from all these different countries came together and looked at these results. What are patients experiencing? What are doctors? What are nurses' experiences? What does the latest research say about what can we do better as a collaborative entity to reduce the burden of diabetes? And an second International Dawn Summit was then established with experts from 25 countries and patients. And they worked out from data, from research, from patient perspective, a global call to action that in the International Diabetes Federation publicized in 160 countries as part of their international diabetes journal, the Diabetes Voice. This Dawn call to action concluded that based on all these insights that we now understand, we need to focus our efforts on 5 things that all countries agree on. And they had to do with the improvement of the communication between the patients and the health professionals, the team-based, multidisciplinary team approach, the importance of focusing on self-management support, the overcoming of barriers to timely start of therapy, and the provision of psychological support. And research and practical strategies were shared among countries, and it was identified that there was no way we would ever succeed with improving things in a measurable way unless we would address it at both the policy level, the healthcare delivery level, and the individual level, and underline this with research. So there are a number of strategies that were lined out and publicized in 2003 and 2004 that have then inspired action in more than 25 countries and allowed the various organizations to build up a critical mass of experience about what is working, what is not working. And I think the important learning here has been that what was really important was the general agreement of the critical non-medical, so to speak, needs of patients in diabetes that are not being met by the healthcare system. That is the insufficiencies of the healthcare system. So we know now consistently around the world that people with diabetes, their absolute biggest concern is that they are deadly worried about future long-term complications, and they're having more depression than other people have, and they're worried and burned out during the daily life, managing their condition, and they're not getting the support they need. So this is a very short summary of that gap between healthcare and diabetes management. And so there's this huge gap of psychosocial and educational needs to function properly as a human being, and then the healthcare system which is not organized for ongoing support, for psychosocial support, for asking into the person. We realize that internationally, and there has been a major development of efforts in that, 4 international summits, and I think the learning from that is that now there's an opportunity with this series to really recap on the exponential increase of research in this field, because there's thousands of publications now on person-centered medicine and diabetes. It's just called different things. And we really need to make sure we bring all that in a structured framework that ensures accountability to action. Because we have come to the point now that there's so much science in this that we can actually assess the fact that still today, more than twice of people with diabetes have depression, 40% have emotional distress due to their diabetes, and more than 60% are having difficulty managing their condition, blaming themselves on a daily basis because they have unrealistic treatment plans that they were not part of creating with their doctors. So it's very concrete. We know what to do. We have the research to support that a collaborative treatment plan, a psychosocial integration of psychosocial monitoring and follow-up. Those things are effective. We need to look now at policy level, at healthcare delivery level, and individual outcomes level at the humanistic indicators in all our countries and make our national diabetes plans and NCD plans accountable to those measures. So it's really, that's the challenge now, that we need to substantiate the research and evidence we have and build a strong case that it is indeed cost-saving or at least cost-effective to implement these reforms in healthcare that allow nurses to be available to patients, that allow all patients to be dealt with on an individual basis, assess their quality of life, follow up on that, ensure that there's community and local and healthcare system resources to support self-management on an individual basis. Those things we have learned, we've understood, we've shared across more than 35 countries actually now, and we need now to take it to the next level. And what I will say is that with partners among the International Alliance and many other organizations are involved now in a new study that's currently ongoing, which is in 18 countries, which is assessing with nationwide samples of patients, family members for the first time, as well as dietitians, nurses, GPs and specialist doctors, nationwide samples looking only at scientific benchmarking of access to patient-centered care, diabetes care. Looking at what are the barriers for doctors to delivering it, what are the drivers of delivering it, and what are the unmet needs from patients and family members. This will allow, because of the involvement of scientific organizations, a beginning of a scientific benchmarking on humanistic indicators which have so far escaped the radar screen for many countries. I can assure you that many national plans are very visionary and very sharp, also global plans. But when you look in the end of it and you look at what are the measures we will evaluate ourselves on, it's mainly the traditional measures of complications, which means when the damage is done. So what are we doing to take a preventive approach and ensure that people are maximally empowered and supported early on when they, hopefully actually before they get the diagnosis, but once they have the diagnosis, what are we doing in a measurable, accountable way to give them the support they need? And I think that's an example of a disease-specific approach that I think can be helpful, because now it's turning into a collaborative network of experts, patient organizations in all these countries who are working together to share better practices, measure themselves against each other, look at gaps, look at opportunities, understand what models of community support work best where. And I think those things can be an inspiration, just as I'm sure that can be inspiration from other disease areas. But I strongly welcome this initiative, and for instance in the diabetes one, we as one stakeholder look very much forward to be very strong support and involved in this, because we all need to be working entirely together on this. No model, I think, can ever work unless we have the payers, the providers, the policymakers, the patients and the family members and the community organizations. All of them need to be on board, but it needs to be managed very carefully, very tight, so we build on top of each other, and we build on top of the knowledge we have. So with that, congratulations on this series, and we look forward to supporting it in every way we can.